Thank you for having me here at this summit. It is a great honor and privilege to be speaking with you for a few minutes. And to introduce myself, I'm Nigam Shah, a chief data scientist for Stanford Healthcare and professor of medicine at Stanford University. I'm going to take some time to walk you through what we think is responsible use of GenAI at a health system. So I come to you with sort of two personas, which are listed here. One of it is what I call my .edu persona, where we write grants, papers, students, graduate PhDs, and so on. The other is a healthcare executive persona, where we worry about quality of care that we deliver, sustainability of the efforts that we have. So it's going to be a two-sided perspective, and I hope it'll be educational, entertaining, and fun. All right, let's dive in. So I started in this role in about March 2022. And at that time, ChatGPT hadn't hit the world, and we were in this universe of what today we call traditional models. These are things that are either classifiers or predictors. You could think of them as a prediction for readmission or a classification for sepsis or something like that. And there, we used to worry about this interplay among the models, the work capacity, and the actions we take. So let's use an example. So let's say you have an image classifier model that can read somebody's CT scan or an MRI and classify whether that person has a hemorrhagic stroke or an ischemic stroke. Now, there are such models like that. I have not built them, but several companies have, and they're pretty good. So you could be in Central California, and if you happen to suffer a stroke, there's a model that can run and diagnose that you have it hemorrhagic or do you have a ischemic. You could also have a policy, and I'm not talking national policy, just like your local policy, that if the person has a hemorrhagic stroke, we should fly them over by an air ambulance to a trauma facility. A surgeon can drill a hole and get the blood out, and the person has much better outcomes. And then the action in this case is removing the blood by surgery, and that has also been shown to be quite effective and useful in improving patient outcomes. So we study this interplay. Now, most of us like to focus on the model and how good it is. Is it biased? Is it performing well across sites? What's the accuracy and things like that? And is the data drifting underneath you? And all of those are worthy goals. But here, what we learned was that the crux was our work capacity. So here's an extreme example. So let's say, there are three humans who have a stroke in Central California. We have one air ambulance. All of them have a hemorrhagic stroke. The first person gets on the helicopter. The other two have to wait till the helicopter comes back or another mean of transportation is available. So that's what I mean by there's this hard work capacity. And we used to study this extensively on our campus. So about 8 or 10 faculty published about 23, 25 papers. So the net summary of all of that is, how do we make machine learning models useful? Most of it gears around this work capacity issue. Can you sustain the action? Do people have the right incentives and so on? So that's where we were in early 2022. And people start writing playbooks for responsible AI. And so for their traditional models, based on what we just talked about, we came up with a process on our campus, which we call a F.I.R.M assessment, fair, useful, reliable models. It's inspired by that interplay, 3 steps, 10 different sort of sub-steps in between them. And we wrote it up in a AnyGem Catalyst publication. And each of these steps, like we could get into, the point being, we know how to do this. And several other sites know how to do it. Duke University, Mayo Clinic, Johns Hopkins. Some of us came together and even started this thing called Coalition for Health AI, which several of you might be familiar with. And I believe Brian Anderson is going to be speaking soon on this conference as well. So we started writing these playbooks. So for traditional models, like we got it, right? I mean, there's enough guidance out there. But what about GenAI? Like 6 months in, we start all this in March. We had like 8 years of prior work. In November 2022, this thing called ChatGPT hits 100 million users in God knows 2 months or something. And in the health system, we're wondering, like, what are we going to do? So we said, all right, let's sit back and pause a bit and figure this out. So the first thing we did is we went to first principles and we wrote this piece about creation and adoption of large language models. And if you look at it from the basics, untuned LLMs were not good at following instructions. So GPT-2, which people don't even remember today, like if you said something like explain the moon landing to a 6-year-old, it would respond explain the theory of gravity to a 6-year-old. Because statistically, those are the most similar completions. But that's kind of unexpected. That's not what I want. And so this thing called instruction tuning happened, which led to the GPT 3.5 and then finally ChatGPT, where we provide the prompt or the instruction. What screening test should I recommend to this patient? There's the context, the EHR, and then the model provides a response. Or rather, in this case, the expert provides the expected response. And there was massive instruction tuning of GPT for that. You could also do something called reward-based tuning or reinforcement learning with the human feedback, as it used to be called, where the model generates a whole bunch of responses and a human says, this one is good. Now, the point is, nobody created LLMs this way. None of the stuff out there was medically instruction tuned at that point in time. So we said, all right, let's see how it works. So we said, all right, let's give this command, summarize from the EHR the strokes the patient had and their associated neurological deficits. We give the EHR in context to a model. The model writes the green box, the human writes the yellow box, and we ask, what happened? Long story short, even in the best case, 34% error rate. And we tried the multiple setups, all in context and RAG and so on. So that basically gave us pause. I was like, wait a second. Is this thing really going to work? So we said, all right, let's see what everybody else is doing. This was our test. This is called MedAlign, MEDALIGN, MedAlign.stanford.edu. So we did a lit review, and we looked at how are people testing and evaluating healthcare or medical applications of large language models. So we reviewed about 520 papers and asked 5 questions. What is the data that the people were using to conduct their test? What is the healthcare task that they were testing? What is the language task being tested? What was the metric of evaluation? And what specialty did the study? So 5 things. So the first one is not on this slide, where it turns out that 95% of the papers were making the claims and conclusions they were making without ever touching EHR data. That was a bit strange. The healthcare task is the top 2/3 of this panel. And you can see this thing called enhancing medical knowledge, which is a euphemism for answering and passing the USMLE questions. And we love that. 222 papers did that. On the language side, no surprise, question answering was the top task. We love accuracy, which is the first column. And then things like robustness and fairness and toxicity, maybe even factuality, like maybe. And then of the top 5 uses in the healthcare tasks, there were these things: making diagnoses, educating patients, treatment recommendations, care coordination, and so on. But I just showed you that when you do it with real EHR data, it doesn't work. Now, all of this, 95% of this was done without EHR data. And then the top specialty was internal medicine that was doing all of these publications. So like, all right, what do we do now? So we said the only way to find out what's going to work is actually try it. So we launched this thing called SecureGPT in January 2024. So we had the results of the survey review in our hand. It wasn't published yet, got published mid-2024. So we launched this in January, and then we started watching what are people doing with it. So this is a private instance of large language models. It's kind of goofily named as GPT. It actually has 18 different models now, Claude, Gemini models, and so on. It's not just GPTs. And this is what we found, what people are doing. So the top 5 uses, you might notice that making diagnoses, care coordination, communication with patients were kind of the same that we were seeing in the previous lit review. And these 2, educating patients and treatment recommendations, were much further down. People were interested in generating medical reports or interpreting medical data, which we call data mining in this plot. So like, if we give people the ability to paste in PHI and EHR in a secure environment, This is what they do. Okay. And we know that these things don't work that well. So how do we move forward? So two requirements emerge from this whole adventure: that the patient record needs to be in context when using a large language model. And I'm talking in the healthcare system, right? I mean, this is not general purpose. So that's why we built something called ChatEHR that we'll talk about shortly. And then the other big lesson was that the real life uses of GenAI or large language models, they need to be benchmarked once before deployment, as well as continuously monitored, because the thing people use it for, the task, can evolve as time goes by. So that's why we built something called MedHELM, holistic evaluation of language models for medical tasks. So let's dive into that one first. So MedHELM, the idea behind that is pretty simple. It was like, all right, let's sit down with a bunch of clinicians, actually 29 or 30 in this case, and define a taxonomy of tasks that we want to do with these language models. So we had about 121 tasks organized into 22 subcategories and 5 categories. And we want to fully specify it in terms of the necessary and sufficient condition about what does it mean to conduct a given task, like create a discharge summary, for example. And then at the subcategory level, not every task level, we went ahead and found public data sets, or in some cases created private data sets, where we would have the medical record, we would have either the expert response or some notion of what constitutes a good response. We would have the prompt that formalizes the task that needs to be accomplished. And we have a metric by which we can adjudicate or judge whether the model's output was good, bad, or ugly. So that converts the data set into a benchmark. It needs to have these 4 things. So we created 35 such benchmarks. Now you can guess, we can then take these benchmarks and present them to various models, look at their output, and given the metric, decide, like, was it good, bad, or ugly? There's plots of this available. There's a leaderboard available at medhelm.stanford.edu. The paper is an archive. It's under review. First line reviews have been done at a major journal. Hopefully in about a month or so, it should be out. So now let's aggregate the task levels into these subcategories, and we can see the results in this way. Now, I don't know about you, but I was surprised that for all of the kinds of things people want to use it for, like care coordination and planning, or diagnosis and treatments, this thing doesn't work that well. And it's not this thing as in one model. Most of them don't work that well. They're pretty good for document tasks like education resources, patient-provider messaging, documenting a visit or a care plan or what have you. That's all the blue that you see here. This is mean win rate normalized and so on. And on the leaderboard, you can see more details at medhelm.stanford.edu. All right, so that was interesting that, yes, they work well for a lot of things, but they don't work well for a few things that we're really excited about. So what do we do? So now we want to build this ChatEHR thing, and I'll come back to MedHelm in just a couple of slides. So what the heck is ChatEHR? So it's one of those things where it evolved, and now it has 3 meanings, unfortunately. It is a platform, a user interface, and something we call automations. So the platform is a suite of APIs that can pack a lot of data sources about one patient into a finite context. So in 1 million tokens or 2 million tokens, and there's a lot of engineering to be done to do this context packing so that you can have that payload on which you're asking the questions. And then we pick the model based on, what's the payload size we have. Some models have very large context. So if you have 2 million plus tokens, we go there. We can break it up into multiple calls as well if needed. And there's 2 ways to access this. Method 1 is something we call an automation, where we're trying to automate rote tasks. And the other one is an open-ended chat interface. So let's just take a quick look. So on the left are the automations. So for example, let's just look at the top row. It's a small hospital, Sequoia Hospital, where Stanford has about 20 beds. And we have some fixed criteria about which patients can be safely transferred there. And so what we have the language model do is essentially read those criteria, which are in a Word document, read the chart and say, can this patient go or not go? And then prioritize them, rank order them for a human to review and say, yep, I agree, this person can go, or no, this person can't go. It's a simple automation. Saves us a lot of time. And there's a whole bunch of other examples like that. And on the right is an open-ended chat interface where in this case, I'm asking, has the patient had a colonoscopy? Can you summarize the report of the colonoscopy? Don't worry, there's no PHI in here. And I'm looking at a 1-year look back period. I can select my data sources. Am I looking at just notes? Am I looking at Kid Everywhere and whatnot? So that's what this thing is. And we did it in 2 tranches. So the first pilot was in early 24 while we were doing the SecureGPT, while we were doing that lit review. In parallel, we already started this process of doing automations using these API calls. And, the crux here that you can only successfully automate if performance is verifiable via a truth set. Of course, data need to be accessible, and you need to make sure that the straightforward criteria, in this case, transfer criteria, don't change like every day, for example. But you have to be able to verify by a truth set. So you can see how this ties to MedHELM. The interactive UI piloted in first half of 2025, 3,000 or so conversations, and you can see the breakdown of the tasks. I just grouped them into the same MedHELM categories. And then we see a bunch of document tasks like note generation, but a decent chunk of clinical decision support, not as much administrative and workflow, which is nice because these things don't really work that well for that. And then this is ideal for open-ended conversations, but it also turns out that people need education on how to use GenAI and what does open-ended mean? Like, how do you tell if something has gone off the rails? So that was our lessons. And back to MedHELM and evaluation. So here's the MedHELM, crux being define a task and a benchmark and evaluate with that. Easy to see how it maps to the automations. A little bit harder to do that for the user interface. So for the automation, pre-rollout, we can create a truth set and quantify performance. And then we also have to do a few basic engineering things of impact and system integrity in addition to just performance. And then post-rollout, we monitor that. Is it performing as we intend? And then we do need to figure out a way to maintain a rolling truth set as time goes on. And so as we're making these outputs, we can ask the human to say, was it good, bad, ugly? Do you agree? And need that feedback mechanism to keep updating the truth set as time goes on. On the interactive side, it's a little bit harder. Pre-rollout, we can do user feedback and focus groups, which is what we did. The thing everybody worries about, hallucinations, got to quantify that. In this case, it was actually less than 4% hallucinations. We didn't have truth sets because we didn't know what people would do with it. But post-rollout, we can analyze the usage logs to identify the tasks the UI is used for. I just showed you a little table on the lower left of 2 slides ago. Then we can sample a small percentage of users for that continuous feedback. And the UI does have the ability to give thumbs up, thumbs down, and a little text box to say what was wrong with that particular output. So we can sample 5% of the users for feedback. And for the predominant users, we probably need to develop labeled benchmarks for the top 5 or so, maybe top 10 use cases, or at least those use cases that in the MedHELM benchmarking don't perform well. So then if we're doing it in real life, we do need a little bit of a prospective benchmark for that. And then last, to close out, we're also working on methods with fact verification. The idea being, if you create a summary, I can decompose the summary into the facts being stated, and then I can go to the source record and say, can I find a fragment of the record that substantiates or entails this fact? That's sort of the essential idea of fact decomposition and verifications. We have a couple of projects around that, and see, can we scale it to a very large user base? Because each summary would probably fork 50 to 20 other API calls for fact verification. So your usage just goes through the roof. And then we can also create synthetic truth sets. Like once we know the properties of what part of the record is being used and the kind of the question, we can create artificial data where the right answer is known and use that for benchmarking and so on. So hopefully that gives a nice flavor for how we can get AI into clinical use safely, responsibly, ethically, and also do that same for GenAI. And it's been a great pleasure chatting with you all. And I will close out with the two teams that make it all happen. The top team is our IT team, and the bottom one is my research team. Thank you.